Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Prag Beniwale sir. And let me share some of the achievement of sir. Sir is PG teacher and unit head at Kamala Nehru Hospital, Pune, chairman of Indian College of OBGY, and president of Menopause Society, Pune, 2018-2022, president of Pune OBGY Society 2022-2023, and national website editor of Foxy 2001 to 2017, and peer reviewer Journal of OBGY of India 2011-2017, Journal of Midlife Health, Chairman Young Talent Promotion Committee Foxy 2088 to 2010, and he is co-editor of 3 books and 18 articles in journals, and delivered operation guest lectures in over 160 Foxy societies, and recipient of Best Paper Prize in AICOG and AMOCGs. And today, sir is going to speak on a very important topic, that is optimizing preconception health, preparing women for pregnancy on the occasion of Pregnancy Awareness Week. So, by taking not much time, I would like to invite sir and hand over this session to sir. Sir, stage is yours. You can proceed from here.
Thank you. Thank you, Faraz. And good afternoon. I bring greetings from Pune, and it's indeed a pleasure talking about one of my favorite topics, that is preconception care. And thank you, Team IJCP, for having me here. Before I start the presentation, there are some important facts which we must remember. 4 out of 10 women report that their pregnancies are unplanned. Perinatal deaths are 50% higher amongst babies born to adolescent mothers. 10% pregnancies uh, among women with untreated gonococcal infections result into perinatal death. Maternal undernutrition and iron deficiency anemia accounts for at least 20% of mortality. And in absence of intervention, the rates of HIV transmission from mother to child are between 15 to 45%. All these facts tell us that why it is important for all of us to offer a preconception care. We know that the life of a woman is really dynamic. They undergo a lot of changes in their body during the adolescent phase. Then they become adults many a times during their late adolescence or in early uh, adulthood. They are forced at times to become pregnant, and then it is important that we intervene the life course of a woman because we want her to be healthy when she becomes pregnant. Although many women intend to obtain preconception evaluation and counseling before pregnancy, most of them don't visit gynecologists. So, for prevention of congenital anomalies, preconception intervention like folic acid supplementation or avoidance of alcohol and medications is important. Some interventions can take months to achieve the desired result. For example, women who are obese, they take a lot of time to attain substantial weight loss or even optimizing medical conditions. So all these situations tell us that it is important that we optimize the woman's health before she thinks of becoming pregnant. So what is preconception care? Preconception care is provision of biomedical, behavioral, and social health interventions to women and couples before the conception occurs. And it aims at improving health status and reducing behaviors and individuals and environmental factors that would contribute to poor maternal and child health outcomes. So the ultimate aim is to improve not only the maternal health outcome but the child health outcome. And here we are looking at short term as well as long term achievement. Coming to the goals of preconception care. So first and foremost, we must prevent unplanned birth. So whenever a woman desires to conceive, that is the time she should go ahead and become pregnant. We must identify potential risk factors which can endanger the mother, the fetus, and pregnancy in general. We must educate the individuals about the risks, options, and interventions and management to reduce risk and reproductive alternatives. We must initiate interventions to provide optimum maternal, fetal, and pregnancy outcomes. So, these interventions would include motivational counseling, disease optimization, and if needed, specialist referral. Preconception care has a positive effect on range of health outcomes. So it could be maternal mortality, low birth weight babies, issues in the newborns, birth defects, preterm births, you name and everything is there. So WHO has developed a package of preconception care intervention which talks about various conditions which are important from the pregnant woman's well life. So nutritional conditions, female genital mutilation, environmental health, vaccine preventable disease, HIV, too early, unwanted, and rapid successive pregnancies. So, all these factors have to be looked at critically and they are addressed in this package of WHO. So there are some evidence-based interventions which WHO recommends, and I think it is worth the effort that we as healthcare providers should look at critically and seriously, which includes screening for anemia, supplementing iron and folic acid, giving right information, education, and counseling, monitoring nutritional status. It is really important because we have both the spectrum, malnourished and obese women who come to us for preconception counseling, screening for diabetes mellitus. Let's not forget that we are the diabetic capital of the world, and we must diagnose, manage, and counsel these women as far as diabetes mellitus is concerned, and not to forget promoting exercises. So, other conditions which would include, in select cases, family planning, genetic counseling, carrier screening and testing, and offering appropriate treatments. And of course, there has to be a community based education where the entire population wide screening is carried out. Coming to the uh, whenever we start preconception care, there are some important components in the reproductive history that we must take. Past obstetric history, where we seek information of each pregnancy in detail, right from the problems related in pregnancy, the issues during childbirth, the outcome of the delivery. And we also look at the gynecological history, where we right from age of menarche to the last menstrual period, the cycle, the length, type of contraception that she has used, any gynecological surgeries in the past, or history of miscarriages in the past. So it is important that we do a risk assessment, and the first and foremost factor for a risk assessment is the age. There was a time when we had more challenges of younger women becoming pregnant, but in urban areas, the age at first pregnancy is now increasing. So, as maternal age increases, the risk of infertility, fetal aneuploidy, miscarriages, gestational diabetes, preeclampsia, and stillbirths also increase. So, we have to make the individuals aware that there are certain risks and consequences of delaying conception until they are in their 30s and 40s. Chronic medical problems like hypertension, diabetes, obesity, mental health issues are really important. We must ask about medications there because there could be some medications which are teratogenic for the fetus. We must also inquire into genetic risks and conditions, so family history is important, and not to forget substance abuse, which is so common these days amongst couples. Vaccination is an option before pregnancy, and ideally, a woman should be vaccinated before planning pregnancy against all preventable diseases. So, if a woman takes MMR or varicella vaccination, she should at least wait for a month before thinking of going ahead with pregnancy. And we must vaccinate women, especially who have sickle cell disease or who have undergone splenectomy, should receive meningococcal and H influenza vaccine given as a single dose. Doing clinical examination is important. Calculate BMI, it will give you the general status of the patient. Look for pallor and edema. Systemic examination is a must, and a thorough gynecological examination is important. There is a basic workup that we can think of, starting with a hemogram. In our setup, we always recommend an HB electrophoresis just to find out the thalassemia status, and we also would like to rule out other hemoglobinopathies. HbA1c, ultrasensitive TSH, and infection screening, especially for HIV, hepatitis B, and syphilis. Anemia, all of us know that it's a major challenge in our country, and we know that whenever the hemoglobin is less than 11 grams percent, we call it anemia. Of course, the degree of anemia, as per ICMR, and this is something we would certainly like to look at critically because it is as per our own population. So, hemoglobin between 10 to 10.9 is mild, moderate is up to 9.9, less than 7 is severe, and less than 4 is very severe. And mind well, there are so many women who still come in the severe category as far as our country is concerned. What are the reasons why a woman develops anemia? And most of them are because of deficiency, iron deficiency being the commonest one, where 60% women are deficient in iron. Folic acid and vitamin B12 deficiency is seen in about 10% women, which is characterized by macrocytic anemia. 30% women will have dimorphic anemia, and in extreme malnutrition, protein deficiency will be responsible for additional anemia. There are certain complications of anemia to the mother. We know that she has a lot of challenges to face during the antepartum period, intrapartum period, as well as in the postpartum period. So these are the women who are at risk of developing preeclampsia, APH. They may land up in preterm birth. And these are the women who are more prone for postpartum hemorrhage, puerperal sepsis, thromboembolism, and even cardiac failure in the postpartum period. Let's not forget the effects of anemia on the fetus. So, we may expect a growth restricted baby, prematurity is common, increased risk of iron deficiency anemia in early infancy, congenital stillbirths. But what is not discussed is the effect on neonate. We must remember that iron deficiency and anemia will adversely affect the fetus and neonate, adding morbidity and mortality. And these feti are impacted neurodevelopmentally, and there could be an intellectual disability, autism spectrum disorder, or attention deficit hyperactivity disorders. So we have to look at anemia rather seriously and give due prophylaxis and treat aggressively. So, giving a balanced nutrition is important. There are so many charts, including one from ICMR, which talks about proper balanced diet during pregnancy. This is something which we must encourage our women even during pregnancy. Iron therapy, it is important that before conception we start iron appropriately. Oral iron therapy is the choice, but in women who do not tolerate oral iron or who fail to respond to oral iron, we have to think of giving them injectable. And there are so many options available as far as injectable is concerned. Ferric carboxymaltose is probably the one which is promoted by the government even in the Anemia Mukt Bharat Abhiyan. Why it is important to talk about anemia? We know that when the adolescent enters the reproductive age group with low iron stores, she will become pregnant and she will suffer from anemia. The baby will be born with low iron and low hemoglobin in status. Uncorrected in anemia in infancy and childhood will result into an adolescent who is low in iron and hemoglobin levels are low, and the excessive menstrual blood loss will worsen the situation. And when this adolescent deficient enters or the iron deficient adolescent enters the reproductive age, this cycle will continue. So all we have to do is to try and break the intergenerational cycle of anemia. The second condition is diabetes mellitus. We know that India is the diabetic capital, and diabetes mellitus per se will have an adverse impact on mother and fetus. There's a huge problem of hyperglycemia in pregnancy, which we are facing. It is one of the most common medical conditions women encounter in pregnancy. uh, it is estimated that 1 in 6 live births occur to a woman with some form of hyperglycemia, 84% of which are due to GDM. And mind well, hyperglycemia per se will have a negative impact on the maternal health, increasing mortality, morbidity, and mortality. And it will also have an adverse effect on perinatal and neonatal morbidity. Let's not forget the long term implications, both to the mother as well as the baby. But the challenge of hypoglycemia is that though it is estimated that 21 million pregnancies are complicated per year by hyperglycemia, but only 3 to 4 million of them are detected and treated. Unfortunately, not many receive postpartum care and lifestyle advice, and these are the women who end up becoming a bigger challenge when they come to us for preconceptional care. The maternal issues like early pregnancy losses, miscarriage, preeclampsia, increased incidence of macrosomia, UTIs, difficult delivery, which could be a preterm birth or instrumental delivery, or even a traumatic delivery, C-section. Women are more prone for postpartum hemorrhage. Infection is pretty common in the puerperium, and not to forget the long-term postpartum problems like weight retention and the development of uh, HDP or HIP in subsequent pregnancy and even cardiovascular diseases. The neonate also suffers. We know that stillbirths are more common, deaths are more common, hyperbilirubinemia, hypoglycemia, etc. make life hell for the newborn, and in general, it is the fetal origin of adult disease that we have to look at critically. How do we do the screening? Screening should be done by DIPSI method, and it is a gold standard now. This particular method can be used even outside pregnancy. So whenever you are suspecting that this particular woman is likely to have impaired glucose tolerance or diabetes, it is prudent that we ask them to do a DIPSI test before in the preconceptional period. So there's a checklist which we have to remember as far as women with diabetes are concerned who are keen on becoming pregnant. We must do their correct weight and nutritional assessment. The HbA1c ideally should be less than 6.5, but less than 7 is acceptable. We must look at the complication screen, so refer her for a fundus examination, rule out neuropathy and microalbuminuria. Check their thyroid function, because these are the women who may have existing thyroid dysfunction. Folic acid should be given at least 3 months prior, and aspirin is at times useful in these women when you're managing them. The next condition, which where 1 in 10 adults suffer, is a thyroid disease, and this is something which we can certainly treat in the preconceptional period, because it is far more common in women rather than in men. And there are certain risk factors for thyroid disease which are noted in the preconception period. So, age more than 30, BMI more than 40, multiparity, medical history, which includes thyroid disease, infertility, RPL, pregnancy complications. Let's not forget the family history of thyroid dysfunction or autoimmunity, and a good clinical examination, which will tell us about the signs and symptoms of thyroid function, and not to forget goiter. The challenges throughout pregnancy are uh, troublesome for the woman. So women may land up with preeclampsia, anemia, low birth weight infants. More women are more prone for postpartum hemorrhage, and even the fetus face challenges like neurological abnormalities, cognitive impairment, or even developmental uh, abnormalities. So these are some of the issues which we must look at critically and try and diagnose the thyroid dysfunction in the preconceptional period. The Indian guidelines on thyroid management of maternal thyroid disorders, where we should do uh, TSH levels in all pregnant women in as early as possible whenever they come to us with pregnancy. So, ideally, screening should be done in the preconceptional period, and universal screening is something which is now suggested because we have a high incidence of thyroid dysfunction in our country. Women with overt hypothyroidism, we should treat them. uh, Women with subclinical hypothyroidism, which is during detected during preconceptional period, should be evaluated further, and we always have a low threshold for starting thyroxine supplement, and of course we would like to have an endocrinologist on board. Overweight and obesity is a new menace. It is found out that 12% of pregnant women in India were obese. In some districts, the prevalence was almost over 40%. So, this is something which we have to look at very, very seriously, because there are so many problems which we can try and prevent in the preconceptional period. We know that obesity will have increased risk of miscarriage, gestational diabetes, all perinatal complications, and poor breastfeeding rates. It will have an impact on the fetus in the form of stillbirths, metabolic abnormalities, and developmental abnormalities. It will definitely have an impact on the children, because these kids will are at high risk of developing obesity and even diabetes. So, what needs to be done is focused preconceptional counseling. Ask them to modify their diet. Aerobic and strength conditioning exercises should be the first line approach in order to achieve target weight loss. And emphasis on either or both. Both is better. Diet and exercise should be individualized according to the patient's profile. Irrespective of pre-pregnancy weight, weight loss during pregnancy is not recommended. Counseling during preconception should be done to achieve a realistic target of 5 to 10% over a period of 6 months. Bariatric surgery, if the woman decides to undergo, she should avoid pregnancy for at least 12 to 18 months. Hypertension, this is a condition which is noted in women now, because more so because they are uh, in their late 30s many a times, and we must screen preconceptionally all women who come to us for a checkup. And here we have to keep in mind the previous history of hypertensive disorders in pregnancy, underlying renal diseases, autoimmune disorders, or even thrombophilias. So, all women with pre-existing hypertension should be advised to achieve a target blood pressure of 150 by 100 in case of uncomplicated chronic hypertension, or 140/90 in presence of a target organ damage. So, here we would like to take a physician on board just to make sure that the woman controls her blood pressures on medications, on antihypertensives, which are acceptable even in pregnancy. Seizure disorders is something which we must look at, because most commonly used anticonvulsants are associated with malformations in the baby. So, good prenatal counseling is extremely important. They should be assessed by a neurologist before they think of becoming pregnant. Mental health issues is something which is again on the rise. So we have to take detailed history, personal history, family history, and even we should inquire about social stressors. The couple should be informed that the potential risk of an untreated illness, where there could be a relapse during pregnancy, and the risk to the fetus from a potential teratogenicity of an antipsychotic drugs. Women with previous miscarriages, they have uh, to be counseled really well, where we must test for conditions like APLA or anticardiolipin antibodies, etc. Genetic counseling and karyotyping, especially if they have three or more miscarriages. Pelvic ultrasound and hysteroscopy to diagnose genital abnormalities. Testing for syphilis and sexually transmitted infections is important. Don't forget thyroid dysfunction and uh, glucose abnormalities, and women who are diagnosed to have APS may be benefited by preconceptional aspirin or early initiation of prophylactic heparin. Infection screening is important, and when we talk about infection screening, hepatitis B, C, HIV, syphilis, chlamydia, and gonorrhea come to our mind. Alteration of lifestyle is extremely important, so avoiding alcohol, tobacco, and all sorts of recreational drugs is a must. Hand washing and other hygienic measures are important. Avoiding consumption of undercooked meats and unpasteurized foods, avoidance of environmental teratogens, and medication change or discontinuation uh, if the medication is unsafe for use in pregnancy. And then there are core interventions which we give it for all. Folic acid supplementation, usually in the dose of 400 to 800 micrograms. We can consider higher doses. Giving additional B12 because it will also reduce the risk of conj anomalies, and even glycemic control is very, very important. This is the FIGO preconception checklist, which we all should remember, and we should have it ready with ourselves in our antenatal clinics. So, in general, we also have to remember that the preconception care has to be offered even to the men. So, we should look at it as an opportunity to disease prevention and health promotion. It improves family planning and indirectly even pregnancy outcomes and enhancement of reproductive health and health behaviors of men and their partners. And of course, this will have a better preparation for fatherhood. And this is in general a strategy for country action. So it is something which has to be implemented for all women who come to us for preconception care. So to conclude, preconception care is a primary care, and providing quality preconception care is responsibility of all primary care providers. Successful implementation requires transforming care delivery and providing preconception care based on the best available evidence. Improving preconception health can ultimately improve maternal and perinatal outcomes. And I would end by this quote, which says prenatal care is one of the most effective ways to reduce maternal mortality because it identifies complications or high risk before emergency situations. So, thank you very much. And once again, thank you, Team IGCP, for having me here for the lecture today.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session will help all the participants on their practice too, sir. Sir, as I can see, sir, we have received some questions, sir. With all your permission, shall we take these
Sure,
questions?
sure, sure.
I can see the first question is from Dr. Vishakhara, and she's asking like, what are the preconceptional health supplement? Please share your point of view on that.
Okay. So the mandatory ones are folic acid and B12. Why B12? Because we find in clinical practice that there are so many women who are B12 deficient, especially in our population, because we are primarily vegetarians, and I mean, most of us do not eat that much red meat to ensure that the B12 values are good. So these are the basic ones. But then, you have to assess each and every patient individually. If you feel that uh, uh, the woman in her preconceptional period is deficient with other factors, she should be supplemented accordingly. Protein is something which is also very, very important to supplement, especially in women who are undernourished.
Thank you so much, sir, for sharing your point of view on this question, sir. Moving forward, one more question from Dr. Sangeeta, and she's asking like in day-to-day OPD sessions, we have one question very common among the patient that they ask what is the lifestyle we should follow while like preparing for preconception.
Okay. So a good aerobic exercise, at least 30 minutes a day, is some, or and for 5 times a week is important. Um, Following a good nutritious diet is important, and if you feel that your client is obese or overweight, we should encourage her to lose at least 5 to 10% weight, so that uh, the optimization of her health takes place. So I think this is something which she has to follow, and of course they should refrain from alcohol, smoking, and even substance abuse. So these are
Thank you
very,
so
very
much, sir.
basic lifestyle changes that one should advise.
Yeah, so thank you so much, sir, for sharing this thing. And sir, one feedback from Dr. Ankita. She has written, wonderful presentation, sir. Thanks for this amazing talk.
Thank you.
And sir, welcome, sir. And moving forward, I can see one last question from Dr. Subramanyam, and he is asking, like, sir, what are the screening? What is the role of screening we should perform prior getting any preconception, sir?
Now, there were two slides which we should remember. Firstly, I mean, what we do in our clinical practice, of course, apart from a good clinical examination, there are certain investigations that we recommend. I work in private sector more, so we get a thalassemia testing done for all. We should also get a good CBC report of this patient, because we would like to know the hemoglobin, and here we would also like to rule out iron deficiency. Thyroid screening is done by ultrasensitive TSH. Sugar testing can be done by HbA1c or a DIPSI test, which will help us. And infection screening test like HIV, hepatitis B, hepatitis C, and syphilis are important. So these are the basic tests which we should suggest for all whenever they come for preconceptional care.
Thank you so much, sir, for answering all the questions, sir. As I can see, sir, one patient question from, sir, like social media, we have got it, sir, from YouTube. And this question
Mhm.
is from Miss Sunita Tamang. And she's asking, sir, my period isn't starting, but my bleeding is going 2 days only. But pregnancy kit test shows negative. Sir, what can be the
Okay.
reason and what can your
No,
point of view on that?
she should see her gynecologist and get this sorted. So this is not the right platform to answer such questions.
Yes, sir.
She
Thank you
has to
so much,
visit
sir.
her own gynecologist, get herself investigated, find out what is wrong with her, and then get herself treated.
Yeah, thank you so much for suggesting, sir. As I can see, sir, there is no more questions, sir. With all your permission, shall we conclude this session for today?
Sure, sure. Thank you so much for that.
Okay. Welcome, sir, and we would like to see you in future also with different topics, sir. Till then,
Sure.
take care of yourself, sir. Have a great day, sir. Thank you.
Yeah. Bye bye. Thank you.
Bye, sir. Welcome, sir.